Alright, so today we'll be covering a talk on ankle fractures. My name's Ben, I'm a third year student from Notre Dame. So going through ankle fractures, we'll go through the epidemiology, anatomy, etiology, diagnosis, classification, then finally treatment of these fractures. So starting with the incidence and epidemiology, a US study found an approximate rate of 187 per 100,000. And this rate's actually increased quite significantly since the mid 1900s, and that's mainly in industrialised countries. Most likely, it's believed to increase numbers of people being involved with athletics and sports, and also our increased proportion of the elderly in our society. Majority of fractures are malleolar fractures. I'll sort of run through what the malleolus is and what malleolar fractures are later, but 60 to 70% are unimalleolar, 15 to 20% bimalleolar, and 7 to 12% trimalleolar. In terms of some risk factors for ankle fractures, cigarette smoking and a high BMI have been linked. And interestingly, bone density, which is quite commonly linked to a lot of other common fractures like wrist fractures and things like that, has no actual correlation, which was an interesting finding. So the general anatomy, the ankle joint is a synovial joint formed from the tibia, fibula, and its articulation with the talus in the wrist here. The sort of significant bony landmarks to be aware of, we sort of mentioned the malleolus before, and that's the medial and lateral malleolus you can see there. I'll also discuss a posterior malleolus later. And then the joint itself is highly ligamentous, and it's sort of formed from three main ligament groupings: the lateral, medial, and syndesmosis ligaments, those syndesmosis being the ones that hold the tibia and fibula sort of together, keeping that interosseous membrane intact. So then etiology, sort of the cause, which I feel a fair few people would be pretty aware of. As you can see in the image, commonly ankle injuries are a result of excessive supination or pronation. So that sort of internal or external rotation, clearly a bit of excessive internal rotation going on here. And then furthermore, twisting force can also contribute. And that just generally depends on the mechanism. Historically, the mechanism of an ankle fracture has been sort of described in two parts. Firstly, the position of the ankle, and then the direction of the force. So an example being a supinated position with an external rotation force applied. So then coming to diagnosis, as with a lot of fractures, X-ray or imaging is our principal sort of way of diagnosing. But I thought it important to touch on the Ottawa ankle rules, which give us essentially a set of criteria determining who we do and who we don't X-ray. Because obviously ankle injuries are pretty common, more common than ankle fractures themselves. So it's just helping us to determine whether certain patients will require an X-ray for an ankle injury. The Ottawa ankle rules have an assessing component for ankle and midfoot fractures. I'll just focus mainly on the ankle. And the general rules are that patients with a traumatic ankle injury will qualify for an X-ray if they have any of the following. And that's point tenderness at the posterior edge or the tip of the lateral malleolus, point tenderness at the posterior edge or tip of the medial malleolus, and an inability to weight bear, so 4 steps immediately after the injury and in the emergency department. The Ottawa ankle rules generally are really well applied, and through proper application, it's got a 97.5% sensitivity and can reduce the need for radiographs or X-rays by about approximately 35%. So when we do X-ray someone and they pass these tests, we generally go for a three view plane X-ray. Typically, we get an AP, a lateral, and an oblique view. obviously we've sort of gone through in previous videos and that the reasoning for multiple images is that you can sort of see different fractures and see different displacement of fractures on the different views. Generally, when we assess the X-ray, we look at the ankle joint as a ring, and I'll have an image sort of showing that ring later on. And you look for breaks in that ring, and the ring itself is formed from the 3 ankle bones and the 3 ankle ligaments. If you find one break, you need to be quite wary of looking for a second break. And generally, like all fractures, you're looking to assess the bony integrity in the joint spaces for any indications of fractures. Obviously, in these images, pretty obvious fractures. So then classification of ankle fractures. The Weber system is generally used. So we've got Weber A, which is a lateral malleolar fracture below the syndesmosis. So you can see that in the image A. And general features seen, but these aren't exclusively seen, is an intact syndesmosis and deltoid ligament, possible medial malleolar fracture, and they're usually stable. Weber B is a fibular fracture at the level of the syndesmosis, possible syndesmotic injury and deltoid ligament and variable stability depending on the actual fracture itself. And then C is above the syndesmosis. So that usually results in a ruptured syndesmosis and torn interosseous membrane, and can involve a medial malleolar fracture or deltoid ligament tear, and quite generally they're an unstable fracture. So some further types of fracture, because there are fractures that sort of go outside of the Weber system. I'm not even going to try a Mason-Neuve. My French is pretty poor. Is a proximal subcapital Weber C fracture. So you see in the image on the far right, you've got that sort of more proximal fracture just under the head of the fibula, resulting in that sort of splitting and tearing of the syndesmosis. And so you usually get a ruptured syndesmosis. You can also have a medial malleolar fracture and deltoid ligament tear. Generally, they're an unstable fracture. And yeah, as I mentioned before, that simultaneous interosseous membrane tear. There's also an avulsion fracture, and speaking with doctors, an avulsion fracture essentially is where the ligament will sort of fracture off or tear off a bony fragment, which you can see in the image. And then a pylon fracture, which is a fracture of the distal tibia, and that usually also involves a fibular fracture. You'll probably notice as well a lot of these fractures described are fibular fractures, as the fibula is a smaller bone and more susceptible to fractures. So then treatment. So firstly, we have to assess the extent of the damage and the stability, and then for the need of orthopedic involvement. I think primarily in emergency cases, you need to assess for things like open fracture or clear neurovascular impairment or impingement, and that will require immediate surgical intervention. So you won't hesitate to call your local orthos. Otherwise, there are some systems to determine the need for surgical involvement. The Laug-Hansen system, and that goes back to our description of position and force, which determines the need for surgical involvement. However, this has gone sort of out of fashion in over time, and its actual application in a clinical setting doesn't really always hold up. The other one is the ring system. So you can see the image here showing that sort of ring formation of the bone and ligament structures. Generally, if there's one break, the structure is stable. If there's two, it's unstable, which would then require further involvement. But generally, it's a clinical sort of decision, and surgical management will be made based on the opinion of a surgeon. So you'll get them involved, and they'll look at the X-ray and also the stability of the joint itself and determine the need for surgery. So then the two forms of treatment, we've got sort of conservative treatment, which is just a closed reduction of the fracture to try and return the bones to normal structure and normal alignment. and then that would also involve stabilization. So cast application, usually a below knee back slab, is what people go for, and you place the foot at 90 degrees, which is a resting position. And you can also place some extra padding around the limb when you are applying the cast, as it can be an area that swells quite significantly. So just being aware that you want to avoid any sort of pressure sores or sort of compression of the joint itself. And then this surgical management, so open reduction and internal fixation. So that's again trying to get that normal bony alignment. The actual technique, I looked a lot around sort of specific techniques and found very little in the resources at sort of our level. But generally what it talks about is the use of plates, pins and screws, and that varies depending on the extent of the fracture, where the fracture positioning is, and all of that. So again, I think that comes down to the clinical picture that you see and also surgical preference. I did want to sort of note one different one, I guess, to wrist fractures that is quite common, is placing a sort of pin or some sort of fixation between the fibula and the tibia, trying to ensure that those bones sort of stay nicely compressed together for that syndesmosis repair and preserving the interosseous membrane. So those are my references. Thanks.